Everyone, and thank you for joining us for tonight's International Dermatology Educational Series webinar. Tonight, as our moderator, we have Dr. Ali Shabazz, Clinical Assistant Professor, Texas A&M School of Medicine, dermatologist at Westlake Dermatology at Westlake's Dermatology and Cosmetic Surgery. My name is Ashley with RBC Consultants, and the title of tonight's program is A Joint Approach for Psoriatic Disease Management, Bimzlex for your patients with PSO and PSA. As our speakers this evening, we have Dr. Khatri, Director, Dermatology, Rheumatology Service, ICANN School of Medicine in Mount Sinai, New York, and Dr. Lamb, Medical Director, Clinical and Translational Research at Atrium Health Wake Forest Baptist, Wake Forest University School of Medicine. We would like to thank our supporter for making this event possible. Tonight, that is UCB. Now, before we begin, if you're having any issues hearing the webinar, you can listen to the presentation using your telephone. Just select Settings and then Phone Call in the audio pane, and the dial-in information will be displayed. If you're having technical issues, please submit your questions in the question pane on the top right-hand side of your screen. And at the end of the webinar, a survey will pop up in your browser, and it will also be emailed to you within 1 to 2 days. We would greatly appreciate it if you could fill out this short survey. Also, within 1 to 2 days, a certificate of attendance will come to you in your email. If you have any questions during the program, you're welcome to submit them in the question pane. You'll find that at the top right-hand side of your screen. Now, without further ado, I would like to pass the floor virtually to Dr. Shabazz.
Thank you, Ashley, and good evening, everyone. It's my pleasure to be here moderating this amazing session. My name is Ali Shabazz. I'm a dermatologist in Austin, Texas, and clinical assistant professor at the Texas A&M School of Medicine, doing clinical research and mentoring residents and medical students. It is my pleasure to moderate this session today. Next slide. I'd like to thank Dr. Leon Kursick for inviting me to moderate these webinars. The International Dermatology Foundation, or IDF's principal mission is to raise awareness and improve dermatological care all over the world, especially in underserviced areas through education. We've been fortunate enough to have world-class renowned speakers in previous webinars, as you can see here. And if you'd like to stay up to date with IDF educational series in the future, please follow us on Instagram, LinkedIn, and Facebook at the following handles, as well as please visit us at www.idefeducationalseries.com to register for upcoming educational events. So it's my pleasure to introduce Dr. Khatri and Dr. Lamb on a joint approach to psoriatic disease management, Bimzlex for your patients with PSO and PSA. First and foremost, Dr. Lamb is a rheumatologist and the medical director of clinical research at the Arthritis and Osteoporosis Consultants of the Carolinas in Charlotte, North Carolina. He is a clinical affiliate at the with Atrium Health Wake Forest Baptist and Wake Forest School of Medicine. Dr. Lamb obtained his undergraduate molecular degree from Princeton University and completed his medical degree at Duke University School of Medicine. He served his internal medicine residency training at Duke University Medical Center and then followed his rheumatology fellowship at Johns Hopkins University School of Medicine. He was an invited house officer at the University of Oxford in the UK, and he was a research fellow at the National Institute of Health. His research has been supported by the Howard Hughes Medical Institute and the Arthritis Foundation. Dr. Lamb has participated in basic, translational, and clinical research in vasculitis, rheumatoid arthritis, psoriatic arthritis, gout, lupus, myositis, Sjogren's disease, and HIV. He's published multiple peer-reviewed studies, book chapters, and abstracts, and Dr. Lamb is a board certified in internal medicine and rheumatology. Dr. Sakshi Khatri is a dermatologist, rheumatologist, and an internist, and one of only a handful of physicians across the United States with both rheumatology and dermatology training. After completing her MBBS from Delhi University in India, she moved to New York to complete her internal medicine residency, followed by a fellowship in rheumatology at the Albert Einstein College of Medicine in New York. During her fellowship, she realized that rheum patients often saw derm and vice versa, and this led her to the decision to pursue additional training in dermatology, which was by no means an easy task. She went on to complete a 2-year-long research fellowship in Rockefeller University under the mentorship of Dr. Emma Gutman and James Kruger, where she conducted clinical trials in atopic dermatitis and psoriasis. She then completed her residency in dermatology at the Icahn School of Medicine in Mount Sinai, New York, and served as a chief resident after completing her residency. She stayed at Mount Sinai and is currently an associate professor. In addition, she's a director of the Connective Tissue Disease Center at Mount Sinai, the director of Inpatient Consult Service at Mount Sinai's Westside Campus, and the program director for Dermatopharmacology Fellowship. Her clinical focus is on inflammatory and autoimmune skin diseases, complex dermatology, and diseases in both rheum and derm overlap. Besides patient care, she's actively involved in research and is a PI for several clinical trials in various autoimmune and inflammatory diseases. Without further ado, it's my pleasure to invite Dr. Lam and Dr. Khatri onto the call. Thank you.
Great, thank you so much, Ali.
Hi, so thank you so much for having us today. Thank you. Okay, let's get this going. Sorry, guys, there's a little lag. Yes, okay, excellent. So I'll start just because we're starting off with the derm aspect of today's discussion. We'll be talking about a joint approach to psoriatic disease management, Bimzlex for your patients with psoriasis and psoriatic arthritis, the first and only approved IL-17A and F inhibitor. I will say right off the bat, as a rheumatologist and a dermatologist, and I'm sure Gordon will agree with me as well, the title is very interesting, a joint approach, because there's a huge push within the derm, psoriasis space to think about psoriatic arthritis, and certainly we've been doing that for years as well. And our patients that have psoriasis, a third of them have psoriatic arthritis, so it behooves us to think of joints even if a patient is coming to see us in the dermatology space for just skin involvement. Before we take a deeper dive, this is a promotional program that's being sponsored by UCB. Both of us have been compensated for the presentation of this information. Everything in this deck is consistent with FDA-approved guidelines, and it's approved for US label only. And certainly, as we hope and encourage participation. So, if there are questions, that would be awesome to have an answer once we conclude this deck.
Yeah, and actually, I just want to really say how much of a pleasure it is to present with you, and to thank everyone who is online with us of spending their time as part of this evening. Let me just go back a couple slides.
Yeah, I know.
Yeah,
the slide deck has a mind of its own.
Yeah, exactly. And the reason why we've been so excited to present this is because psoriasis and psoriatic arthritis, at least in rheumatology, are such complex diseases. In psoriatic arthritis, there's not only skin involvement and joint involvement, but patients can have enthesitis, dactylitis, axial involvement of the spine, ocular inflammation, inflammatory bowel disease, depression, metabolic syndrome, liver enzyme elevation. So it's this very multifaceted disease, and therefore it has a multifaceted impact on patients' lives. Patients with psoriatic arthritis often have this very long and torturous journey where they're seeing all these different specialists, and each specialist views their disease from a very unique perspective. And they kind of don't put everything together until the patient sees a dermatologist or a rheumatologist, and he or she's able to finally invoke Occam's razor and have a unifying diagnosis. It always likens to that parable of the blind men touching an elephant, different parts of an elephant, and thinking that they're touching a completely different thing, when in point of fact it's all the same elephant. And with patients with psoriatic arthritis, because they have all these different manifestations, the diagnosis could be delayed for several years. Now, the hallmark is systemic inflammation. From a joint perspective, it can lead to pain, structural damage, that can lead to increased physical disability, reduced quality of life, and then it can then have a tremendous burden on the patient's mental health, leading to increased rates of depression and even suicidal ideation and behavior. So GRAPPA and EULAR have recommendations. The American College of Rheumatology also has recommendations, but honestly, I like GRAPPA and EULAR's recommendations better. And they really put forth a multidisciplinary collaboration as being essential for the diagnosis and management of patients who have this range of psoriatic manifestations. The GRAPPA guidelines also say that we should take a domain-based approach, and that selection of medication should really try to take into account as many domains as possible. Now, if we do this, and if we have a collaborative approach, it can lead to earlier diagnosis, earlier treatment initiation. That may lead to a lower set point of disease activity. And hopefully our goal is to preserve function and quality of life, and to induce remission, although at least remission from a rheumatology standpoint really hasn't yet been defined. So the question is, how do you do that? And actually, what I'd like to do is kind of ask you about how you approach your patients with psoriasis, and the evaluation of whether or not they develop psoriatic arthritis. You had mentioned about 30% of them will actually
Right.
develop arthritis. So what's your approach when you see a patient in your dermatology clinic?
Right. So I'm going to say I'm like a little biased, but if I were to put just my derm exclusive only hat on, I will say that the best questionnaire is perhaps the best questionnaire that is out there. It's free to use. You can print it out. You can hand it to your patients while they're waiting to be seen by you. You don't have to really proactively ask anything. The patients read and answer yes or no. So it's a very easy, easily understandable question to answer, even from a patient's perspective. And a score of 3 or more, indicates the possibility or likelihood of psoriatic arthritis. So as a dermatologist, if I feel comfortable in making that systemic intervention, if I'm thinking of that from a psoriasis perspective, taking that into account, or referring them out to my friendly rheumatologist who I have on speed dial, could be something that I use the PEST questionnaire to help stratify or triage, or risk stratify in some ways. Gordon, I like your point where you said that it's kind of like the elephant, and if you ask blind people to touch the elephant, everybody describes the elephant differently, but eventually it is, it's the same elephant. So I remember when I was a room fellow, 12 years ago, we just thought of PSA as like arthritis, and nobody thought of the other domains. Like the concept of other domains of PSA didn't even come into existence. So I've really seen the PSA and psoriasis, or just the psoriatic disease space, evolve so much that we are now thinking of systemic inflammation. We are thinking of the different domains. We're thinking of extra articular manifestations, extra, cutaneous manifestations. We're thinking of perhaps IBD, and you articulated it very well that, we have so many different therapies now. What are the domains of involvement? What's the data on that? And of course, we will take a deep dive into IL-17A and F. We talk about Bimzlex and how it performs across all domains of PSA, or psoriatic disease. Now, Gordon, passing the question to you, what do you want us in the derm space, as the rheumatologist, what do you want us dermatologists to think of when we just see a psoriasis patient in our practice?
Yeah, so even though this PEST questionnaire is very useful, it's very easy. You can have your patients fill this out as they're waiting to see you. Um, I would argue that for me as a rheumatologist, it should be even simpler for all of the dermatologists out there. Just simply ask ask the question to your patients with psoriasis: are you having any joint pain? And if they say yes, that should warrant a referral to your rheumatologist, your local friendly rheumatologist. And the reason is because not only could there be psoriatic arthritis, but there could also be osteoarthritis. We know that patients with psoriasis have an increased rate of gout because of the increased turnover in the skin, causing increased uric acid development. So it's the burden of the rheumatologist to make sure there isn't anything else going on. So while this PEST questionnaire is fine, feel free to just ask your patients if they have any joint pain, and if they do, then to refer them on. And I think any rheumatologist worth his or her salt should be willing to take on that evaluation. Actually, so I'm trying to advance the slides. It's not advancing. Sakshi, if you could,
Let's see.
yeah. And actually, why don't I just defer to you, and then we can I'll just ask you to advance slides accordingly.
Yeah, let's do that. But I think we went one slide too many. Actually, can we go a slide back?
Yeah, and the slide back was just to kind of say that patients really want the highest level of disease control. Whether they have psoriasis, and about studies have shown that 40% of patients with psoriasis are unsatisfied or uncertain with their current treatments. 90% of patients place high importance on a rapid response. So not only is having a response, but how quickly you achieve the response is very important. In dermatology space, patients want a PASI 100. And similarly, in the psoriatic arthritis space, patients can still have disease activity, and that can pose a significant burden. In rheumatology, we're used to noting a 20% improvement, 50% improvement, but patients can continue to have pain, fatigue, sleep disturbance, impaired physical functioning, even if we achieve these goals. And in fact, a quarter of patients with 4 or more affected joints report great difficulty with even simple things like bending down to pick items off the floor. So we really need to proactively not only diagnose patients, address them, and treat them really quickly. So next slide, please. And the next slide is where we sort of segue into talking about Bimzlex, the first and only approved biologic to selectively target both IL-17A and F. And the next slide, please. in both psoriasis and psoriatic arthritis. Now, one of the first questions we have to ask is, why A and F? And I should mention that the background is that Bimzlex is not simply a Me-too IL-17A inhibitor. It actually is a slightly different mechanism by blocking A and F. So just in terms of background, the IL-17 family has 6 isoforms, 6 homologs, IL-17A, B, C, D, E, and F. These are naturally occurring cytokines, and A and F have a high degree of homology. They can exist as either homodimers, so AA, FF, or heterodimers, AF. And it turns out that IL-17A and F are elevated in several immune-mediated inflammatory diseases, or IMIDs, and they play key roles in driving chronic inflammation and damage across multiple tissues and disease organ states. Now, the difference is IL-17A is more potent and found early in disease, whereas IL-17F is more highly elevated in lesional skin and serum of patients with psoriasis, psoriatic arthritis, axial spondyloarthritis, and hidradenitis suppurativa, and is found later in disease. So by targeting A and F, we get a broader and deeper inhibition of the IL-17 pathway. Next slide, please. Now, IL-17 can come from 2 different sources, both from the adaptive immune system and the innate immune system. Now, the adaptive immune system is IL-23 dependent, whereas the innate is IL-23 independent. But regardless of the source, the downstream manifestations can include psoriasis, dactylitis, inflammatory arthritis, enthesitis, and hidradenitis suppurativa. And next slide, please. And the next slide sort of demonstrates in a more graphic form the mechanism of Bimzlex. So Bimzlex is a humanized monoclonal antibody, and it combines both the homodimers of AA and FF of IL-17, as well as the heterodimer of AF. And in doing so, it blocks these cytokines from attaching to its receptor complex, thereby blocking downstream mechanisms of disease and inflammation. Next slide, please. So actually, that's kind of the immunology behind that. But I think the key is in transforming the immunology to the clinical efficacy in our patients whom we see every day.
So that's an interesting segue to the derm part, and that's what we'll start with. We talked about IL-17A and F, and expressions, lesional skin and psoriasis, X amount higher in psoriasis in synovium of patients that have psoriatic arthritis. But you will see as we go through the deck that really the Bimzlex head-to-head study with secukinumab, which is just an IL-17A blocker, and the fact that it met its primary endpoint and was superior to secukinumab sort of rests any doubt that blocking F does not matter, and it clearly shows that there is incremental benefit in blocking IL-17F above and beyond blocking IL-17A. So sort of talking about what is the clinical trial data that's out there. We've had 70,000 and plus patients being treated with Bimzlex worldwide, 12,000 total patient years of exposure across all indications. So a lot of robust safety data, 5 years of data in psoriasis with no new safety signals, 14 phase 3B and 3 clinical studies in psoriasis, psoriatic arthritis, non-radiographic axSpA, ankylosing spondylitis, and hidradenitis. So, breadth of data that we have to go through in the next few slides. And sort of segueing into the skin part. Next slide, please. We'll eventually get there. And we'll go to the next slide, please, Ashley. Thank you. And you'll see it talks about Bimzlex reaching a high bar for clinical outcomes. We're looking at PASI 100. And then in the arthritis space, for the first time ever, we are looking at an ACR 50 response. Gordon, before I talk about this, what does an ACR 50 mean? Because we've historically had ACR 20 in psoriatic arthritis, but just raising the bar to ACR 50, how does that mean? What does that mean for you as a rheumatologist? What does that mean for your patients?
Yeah, so I'll be honest with you, even though an ACR 50 is a very high bar, in fact, it was one of the boldest clinical outcome measures proposed. From a patient's perspective, a 50% improvement may not mean that much. If someone starts off with 20 tender and swollen joints and they go down to 10, it's still impacting their activities of daily living and their quality of life. We want ACR 100, so 100, a complete resolution. And actually, as we kind of go through the data, both in the skin and the joints, we'll see that one of the unique evolutions of the Bimzlex clinical trial data interpretation was as they were going through the clinical trial data, at least with regard to psoriatic arthritis, they noted that they not only met the ACR 50 threshold, but they began to see complete resolution of signs and symptoms of disease, and hence a new kind of paradigm by which to look at psoriatic arthritis, which is complete resolutions of signs and symptoms of disease. But why don't we start with the skin, and then I think that will make a really nice transition to its effects in the joints.
Because in the derm space we are certainly spoiled. We do have complete clearance. This slide just talks about week 16 data across phase 3 pivotal trials, and the beauty of this slide is that you can see that, hey, we have the first study which was against placebo, which obviously we are supposed to have, and you're looking at a PASI 90 response of 91%. When you're looking at another head-to-head comparison versus ustekinumab, which is an IL-12/23 blocker, you're looking at, again, a PASI 90 response of 85% for Bimzlex, 50% for ustekinumab. The third study was versus adalimumab, which is an anti-TNF, so 86% PASI 90 response for Bimzlex, 47% for adalimumab. And last, the slide that I already, the clinical trial that I referenced to earlier, you're looking at a head-to-head comparison with secukinumab, which is an IL-17A only blocker. And once again, you're looking at a PASI 90 response of 86% for Bimzlex versus 74% for secukinumab. I think I love this slide as a dermatologist, and even as a rheumatologist. We don't really get a lot of head-to-head studies in the rheum space. So, any data is better than no data. So here you have a slide that sort of summarizes Bimzlex, which is an IL-17 ANF blocker, versus different MOAs that are out there. And you can clearly see that Bimzlex outperforms. The second thing that I would like to call out is that this is looking at 4 doses of Bimzlex versus certainly different, or higher doses for secukinumab, higher doses for adalimumab, 2 doses for ustekinumab, 4 doses obviously for placebo. But the consistency of PASI 90 responses across all these 4 clinical trials is what really catches my attention. Next slide, please. Ashley, next slide, please. And then in the next slide, you will see the mean PASI response, because, PASI 90 response is a clinical trial metric. It is something that we use in clinical trials because we have to. But patients don't understand what a PASI 90 response means. Often we have patients ask us, so, hey, doc, you're putting me on this medication. What will I see? And then I think the answer to that question lies in this slide in front of you, which talks about a mean PASI improvement. And again, I would want to point out that this is 4-week data. So patients got 1 dose of Bimzlex, 320 milligrams at day 0 or week 0, whatever you call it. And at 4 weeks, their PASI responses were calculated based on the amount of psoriasis that was left on their skin. And you can again see consistency of response across 4 clinical trials, whether it's Be Ready, whether it's against placebo, whether it's Be Vivid against ustekinumab, whether it's Be Sure against adalimumab, or Be Radiant versus secukinumab. Again, you see a mean PASI improvement that is 80 to 83%. Again, numbers that are extremely consistent. So you can clearly tell a patient that upwards of 80% of his or her psoriasis is going to be all clear right off the bat from the first dose when they come back 4 weeks after getting that first dose. Next slide, please. And then this is the slide which talks about PASI 100, because in the derm space, Bimzlex has really raised the bar. We are looking at all clear. Patients with psoriasis don't want to have that plaque that's left behind. They want to be all clear. So you can clearly see that 60% of patients achieved PASI 100 at week 16. If you draw your attention to the extreme right side of the slide in front of you, and that's the Be Radiant clinical trial versus secukinumab, and PASI 100 was the primary endpoint at week 16. It was statistically significant for Bimzlex versus secukinumab, and once again, sort of laying rest to any doubt that blocking IL-17F does have incremental value, because you can clearly see that in this clinical trial, Bimzlex, which is blocking IL-17A and F, is superior to secukinumab, which is just an IL-17A blocker. Okay, hopefully the slide advances because I'm trying to move it, but if not, yep, excellent. And then, we do have 5 years of open label extension, which is the Be Bright study, and we have open label extension 1 and 2. 2 is a little different because that only has US and Canadian patients. And if we move to the left side, we will really see, the depth of response that stays over a long period of time, because we know that psoriasis is not a sprint, it's a marathon. And again, if you can go one slide back, it talks about the data in the open label extension. These are actual clinical, these are patients who are being treated with Bimzlex in the real world. If you see that week 0 data and week 3 scalp, you can clearly see scalp psoriasis melt away. And again, we do know in clinical practice that scalp can be a difficult to treat, area of psoriasis for patients. Okay, I'm going to go one slide back because we kind of skipped over the open label extension. Yep. Okay, excellent. So just to sort of summarize this slide tells us if patients entered the open label extension with a PASI 90 response or with a PASI 100 response over 5 years, how many patients sort of held on to that PASI 90 and PASI 100 respectively. So I'm going to say it very slowly, and that's the heading of this slide, which is 77% remained completely clear for up to 5 years of treatment with Bimzlex. Almost 8 out of 10 patients were all clear when it comes to their psoriasis on this medication. And that's a very powerful statement to make and to tell a patient that, you know what, I'm putting you on this drug. You'll see a mean PASI improvement at 4 weeks after that first injection. You'll reach a PASI 100 response. And guess what? 8 out of 10 times you will stay all clear 5 years of being on this medication. So again, psoriasis is not a sprint, it's a marathon. Patients want a drug that will work for long periods of time. Clinicians want a drug that will work for long periods of time. And this drug really performs when it comes to that. We've already seen real world images of patients doing well on Bimzlex. I went over this slide previously, so I'm going to move along. And again, palmoplantar psoriasis, another hard to treat area. And you can see before and after, robust responses, all clear, almost clear. And these are, again, real world images of patients who are being given Bimzlex for their psoriasis by physicians that they're seeing in practice. Okay, Gordon, all yours.
Yeah, so the skin is extraordinarily compelling. And from a rheumatologist perspective and from a psoriatic arthritis patient perspective, the skin can be really compelling. Skin can be patients can be so self-conscious of the disease, but the joints, for them at least, are what's impactful with regard to their activities of daily living, quality of life. So Bimzlex was studied in both bio-naive and bio-experienced patients. The seminal trials were Be Optimal for the bio-naive patients, Be Complete for the bio-experienced patients, and patients were simply randomized in a one-to-one fashion. I'm going to go over the endpoints very quickly. If we can just go back a slide. And first was that the ACR 50, so 50% improvement in the joint counts and in the joint manifestations, before was considered a very high bar. And you can see that despite this high bar, patients who were treated with Bimzlex, whether they're bio-naive or bio-experienced, over 40% achieved an ACR 50, as opposed to only about 7 to 10% in those who were treated with placebo. And then when those who were in the placebo arm were switched to the Bimzlex, we begin to see an increase in response as well, a catch-up response, if you will. But I think what's more compelling is when I go to the next slide, we see the responses over time. And just like how Sakshi had mentioned, the durability of response in the skin over 5 years, we see a similar trend in durability of response in the joints over time as well, this time up to 2 years. And here the graphs on the left and the right are the two trials, Be Optimal, Be Complete, bio-naive and bio-experienced patients respectively. The top line is the ACR 20 response, that's the blue teal line. The middle sort of yellowish green line is the ACR 50 response, and the bottom sort of bluish green line is the ACR 70 response. And you can see the improvement in symptoms up front. That seems to suggest quick response over time. And then in these longitudinal response curves, we see that the slopes remain constant. That is, they do not drop off over time. So kind of looking at the data like this gives us hints as the characteristics of the drug just by looking at the morphology of the curves. And the fact that they don't drop off over time indicates this durability of response. Now, the reason why that's important, at least from a psoriatic arthritis standpoint, is because I was asked to partake in this study a couple years ago. And I'll be honest with you, I wasn't too excited to be part of this study when I was first asked because I thought the study wasn't scientific enough. The study was simply asking patients with psoriatic arthritis what was the most important factor to their care. And I thought, well, that answer is obvious. It's going to be how effective a medication is or how safe it is. The responses of the patients, though, really surprised me. They weren't those responses, and it's because of the unexpected responses that why the study got a lot of public publicity. What patients said was the most important factor to their care was how long a medication lasted. They said that every time a medication was started, there was this angst, there was this uncertainty. Would a medication work? Would they have side effects from it? Would they be able to afford it? Would it affect their job, their family, etc.? And every time a medication stopped working and a new medication was substituted, that whole angst and uncertainty recycled. What patients wanted was a medication that once it was started, it would work forever. They could literally set it and forget it. And as you folks know, with TNF inhibitors, their effectiveness or efficacy wanes over time. And that's been demonstrated not only in the skin, but in the joints and in the gut as well for patients who have inflammatory bowel disease. So it's this longevity of response, this durability of response, this survivability, whatever you want to call it, that's critically important to patients. Now, I had mentioned that the response for Bimzlex appeared to be very robust. And in fact, when they were evaluating the clinical trials, the researchers were a bit surprised at how robust the results really were. It came to this, what I like to call a wall of zeros. So the zero is complete resolution of signs and symptoms of disease, so zero disease activity. And at least in the psoriatic arthritis realm, whether it was bio-naive or bio-experienced patients, anywhere from 2/3 to 3/4 of patients experience complete resolution of swollen joints. About 2/3 to almost half of patients experience complete resolution of tender joints. About 2/3 of patients had complete resolution of enthesitis. Over 90% of patients had complete resolution of dactylitis. About 3/4 of patients had complete resolution of skin psoriasis. About 70 to 80% of patients had complete resolution of nail psoriasis. And about 89% of patients had inhibition of radiographic progression. So inhibition of radiographic progression is important from an arthritis standpoint because it's a surrogate for structural damage, which in and of itself is a surrogate for preservation of function. So the fact that Bimzlex delivered zero radiographic progression in 89% of at least bio-naive patients at week 52 is important because that's a really good prognostic sign that these patients will do well over time. Now, I had mentioned the wall of zeros. This is just showing longitudinal response curves of these patients, showing that the responses were fairly quick, usually within the first 8 to 16 weeks. They were very robust and durable throughout time. So with regard to complete resolution of swollen joints, about 70% of patients experienced complete resolution of swollen joints, regardless of whether or not they had received biologics before or were naive. But more importantly, though, is if you can look at the baseline swollen joint counts, which I don't know if you can see my mouse, but the baseline joint counts were 9 and greater than 9. So these patients had a lot of swollen joints. It went down to 0 in as quickly as 1 to 2 years. Next is looking at enthesitis. So enthesitis is inflammation of tendons or ligaments into bone. Enthesitis is considered to be one of the most recalcitrant and difficult to treat manifestations of psoriatic arthritis. And again, most patients who were treated with Bimzlex were able to experience complete resolution of enthesitis in both bio-naive and bio-experienced patients. And their baseline was to almost 3 tender enthesial points as well. So now when I tell patients that our goal is to completely resolve their enthesitis, it gives them a lot of hope. Enthesitis can be, again, one of the most troubling and recurrent manifestations of disease. I think that one of the greatest things we can give as providers is hope to our patients, optimism. But the hope can't be false hope. It really needs to be grounded in evidence and science. Next is a complete resolution of nail psoriasis. This is by the modified NAPSI. And again, up to 70 to 80% of patients were able to achieve complete resolution of nail psoriasis over the course of 2 years. And again, when you look at the baseline modified NAPSI, they started with a score of greater than 4. So having complete resolution of nail psoriasis can be very poignant and meaningful for patients as well, because oftentimes that can be a point of cosmetic and an area that patients can be very self-conscious of. Now, in psoriatic arthritis, pain and fatigue can be overwhelming. These are subjective measures, and for most rheumatologists, it's the bane of our existence. Asking about pain, asking about fatigue, because they can be so multifactorial. In fact, oftentimes rheumatologists, myself included, are very hesitant to ask about fatigue because you can go down a rabbit's hole. It can be due to the disease itself. It can be due to medications, depression, life and social stressors, etc. But the point is that with Bimzlex, if patients achieved 0 swollen joints, it was associated with greater improvements in pain and fatigue. So if they had 0 swollen joints, complete resolution, then almost 70% of patients reported a 50% or more improvement in pain. And the majority of patients, about 56%, had improvements in their facet fatigue score. It was above the minimally clinically important difference, which is 4 points or more. And for patients, again, that can be clinically significant. So again, having this data, we can, in our back pocket, we can tell patients that if we treat them with Bimzlex, they may have improvements in not only all of those objective manifestations of disease, but 2 of the most burdensome clinical manifestations of the pain and fatigue as well. So the efficacy is one side of the coin, safety is the other. And Sakshi, let me turn it back over to you to talk about the safety profile of Bimzlex.
So, moving along, we have up to 5 years of well-studied safety profile in psoriasis. There have been no new safety signals over 5 years of data that we have. And, sort of just looking at short-term data, because safety data is short-term, what's happening at that primary endpoint, which is week 16 for our psoriasis patients and for our psoriatic arthritis patients. And then there's long-term safety data, which we'll talk about subsequently. So really, for me, I talk about, oral candidiasis. So yes, patients that are being given, Bimzlex and IL-17A and F blocker, you will see rates of candidiasis, which if you look at the slide in front of you, it's 9.1% in Bimzlex, 0% in placebo. And within that candidiasis or spectrum of infections, it is really oral candidiasis. So when I'm having a discussion with my patients and I'm putting them on Bimzlex, I tell them, hey, listen, there's oral candidiasis in the clinical trial. I personally have seen oral candidiasis. Anything from 1 to 2 out of 10 patients get that, but it is oral candidiasis. It's in your mouth. And as dermatologists, it's rather easy for us to treat oral candidiasis. Nystatin, oral fluconazole. So it's not something that we are not known to or used to treating. The second is LFT, AST elevation. And again, if you see the percentage values, it's 1.3% in Bimzlex, 1.2% in placebo. Again, the reason why I point that out to patients is because if you see the package insert, I'll talk about LFT elevation. I personally, in my practice, do not monitor any LFTs. Certainly, Gordon will have a different take on that because he's a rheumatologist, and rheumatologists love doing blood work. But again, there is no association of AST, ALT elevation with Bimzlex. Really nothing in terms of a signal for malignancy, not a signal for serious infections, no signal for adjudicated MACE or IBD. Because again, when we're thinking of IL-17 blockers, we think of, will this aggravate, cause, worsen IBD? 0.1% in Bimzlex, 0% in placebo. Adjudicated suicidal behavior ideation, 0% for Bimzlex and placebo. And again, we take a deeper dive into long-term data and we sort of focus on these, AEs as well. Now, looking at our psoriatic arthritis patients, again, Gordon pointed out to a wall of zeros when he was talking about the PSA clinical trials. A lot of zeros, a lot of single-digit numbers for Bimzlex versus placebo. So really nothing that pops out in terms of a safety signal to talk about. Right, and this is short-term data. Next slide, please.
And I'll just mention that from the psoriatic arthritis standpoint, the Candida infections were low. The majority of them were mild or moderate. They were not severe, and they were easily treated. And then also the items of concern that we usually really raise eyebrows at, whether it's MACE, that's major adverse cardiac events, inflammatory bowel disease, or suicidal ideation behavior, at least in the psoriatic realm, were zeros, as you can see in the previous slide. But Sakshi, let me turn it back over to you to kind of talk more about this slide, and then I'll be happy to talk more about suicidal ideation behavior.
Right. So this is looking, so again, this is not a sprint, it's a marathon. We looked at short-term data, but what about long-term? Because, we have 5 years of data with Bimzlex, and this is reported as events per 100 patient year. 100 patients on Bimzlex followed for a year, what events were seen. And again, you see oral candidiasis, 8.9 events per 100 patient year, up to year 4, year 5, 7.6. And again, as Gordon pointed out, sort of numbers are also consistent in the PSA space, and we know how to treat oral candidiasis. In terms of other signals, malignancies, serious infection, MACE events, IBD, adjudicated, suicidal behavior ideation, we're really not seeing anything in terms of a signal. And I know we'll take a deeper dive into adjudicated suicidal behavior ideation, because that is sort of perhaps the elephant in the room that we have to think of when it comes to this drug, just because of the package insert. But again, would like to point out there is no REMS program, there's no consent, there is no causal association with Bimzlex and suicidal behavior ideation. Next slide, please.
Yeah, and with regard to that, what I can say is that in the pooled analysis of data from the placebo-controlled trials, suicidal ideation behavior was an issue of concern, mainly because of some of the historical signals seen with other agents. So during the Bimzlex clinical trials, patients were proactively evaluated for suicidal ideation behavior at each visit. Now, in the psoriasis study, 12 out of 670 subjects had passive suicidal ideation. That represents 1.8%, and compared to 0.6% of placebo-treated subjects. That was only 1 out of 169 subjects. That led to an estimated relative risk of 3.0. Of the 12, there were 3 suicide attempts. This represents 0.04 out of 100 patient years. And 2 of these subjects of the 3 had a history of prior suicide attempts. Of the suicide attempts, there was 1 completed suicide. This represents an event rate of 0.01 per 100 patient years, and that subject did not have a past reported psychiatric history. Now, in the psoriatic arthritis arm, the rates were a bit lower. So passive suicidal ideation occurred in 2 out of 698. That represents 0.3% compared to 0.7 of placebo-treated patients, so less than the placebo. This led to an estimated relative risk of 0.35. Of these, there was 1 suicide attempt out of 1,413 subjects. This equates to an event rate of 0.04 per 100 patient rates. And this patient was, this subject had a pre-existing psychiatric condition, and it did not lead to a complete suicide. So I guess what we can say is that Bimzlex may increase the risk of suicidal ideation behavior, but a causal association between Bimzlex and increased risk of suicidal ideation behavior has not been definitively established. But regardless, patients should be advised and caregivers should be advised to monitor and seek medical attention for emergence or worsening of depression, suicidal ideation, or other mood changes. But Sakshi, what I'd like to do is to kind of get your perspective from a dermatologist view about suicidal ideation and behaviors in the general psoriasis population.
Right. So that's an excellent segue into this slide. And I'll tell you, of all the slides in the deck with regards to, suicidal ideation, this is perhaps the best slide that I like, best slide. And I encourage everybody to, pull their phones out, scan the QR code to link to the publication that's associated with this slide, because it really puts things in perspective. Throwing numbers versus placebos perhaps might not be as informative, because there is an inherent risk of depression, suicidal behavior with psoriasis in general, right? And then how does it compare to other, MOAs that are out there? So looking at that slide in front of you, starting from the extreme right, where it looks at patients with psoriasis and their, incidence of suicidal behavior ideation, you can see that the events per 100 patient year is anything from 0.09 to 0.54. As you move from that incidence of patients with psoriasis to, hey, what's happening with IL-23 blockers, again, you see an event per 100 patient year of anything from 0.09 to 0.19. Certainly, an anti-IL-17 receptor, brodalumab, which is approved for psoriasis, not approved for psoriatic arthritis, has a higher incidence or events per 100 patient year. But when you look at IL-17As, again, numbers that are lying within the patients with psoriasis comparable to IL-23s. And when you see Bimzlex, which is an IL-17A and F blocker, it's 0.13 event per 100 patient year. Again, comparable to other MOAs that are out there, whether it's an IL-17A, whether it's an IL-23 blocker, and within sort of that range that you expect to see with patients with psoriasis. So really, again, can't emphasize enough that there is no causal association between treatment with Bimzlex and increased risk of suicidal behavior and ideation. And again, when you just look at these events, compared to other MOAs, compared to patients with psoriasis, it sort of puts a greater understanding on the risk that is associated, risk or the lack of risk associated with blocking, IL-17A and F in patients with psoriasis. Next slide, please. Okay. And we initially I talked about the LFT AST elevation that is mentioned in the package insert. Now this is a forest plot looking at Bimzlex versus placebo, or Bimzlex versus adalimumab versus secukinumab, or versus ustekinumab. And you can clearly see that, across different clinical trials, comparing it with the active comparator, or, the comparator that was being investigated, whichever, study it was, really the events or the incidence or the risk of, Bimzlex causing LFT elevation is either comparable to placebo, or it is lesser than the active comparator. So in my practice, I do not even measure liver enzymes. I mean, I would do a baseline just because, if a patient hasn't seen the primary, or if I'm sort of being the primary, or if there's a lab that wasn't done in the last 6 months, I'll probably do just a baseline CBC CMP just to have a comparison point. But I really don't even monitor labs on follow-up. I'm sure Gordon probably has a different take on labs, because in rheumatology, we love doing labs every 3 months. So Gordon, what's your take on doing blood work when, for any patient that you have in systemic therapy, perhaps?
Yeah, so actually, Bimzlex, you really do not need to monitor routine labs. But as you mentioned, rheumatology, that's what we do. I probably order labs just to make me feel better. That's sort of our knee-jerk reaction. But you're absolutely right. One of the things that we've noticed was the consistent safety and convenience of Bimzlex over time.
But exactly, like, patients gonna ask me, they're like, so I don't need any blood work, and I'm like, absolutely not. There's no blood work that's needed. So it's kind of like a very easy, medication for us, because we don't have any lab monitoring that's needed. Okay, so the third thing that we've sort of talked about is oral candidiasis, and Gordon alluded to, most of these candidiasis patients were mild to moderate. So 95% or higher of candidiasis cases were either mild to moderate, and only 17 out of thousands of patients on Bimzlex discontinued it due to candidiasis. Majority of the events happened in the first year, and majority of patients that had candidiasis just experienced one event in the first year, right? The incidence of oral candidiasis decreased with continued exposure over 2 years of Bimzlex. And again, we are no stranger to treating patients with candidiasis. Nystatin or oral fluconazole worked. In the clinical trial, it was the discretion of the principal investigator, the primary investigator, what to give them, how long to give them for, and the median duration of antifungal treatment within the clinical trial context was 12 days. So again, I've seen few cases of oral candidiasis, nothing that has not responded to either nystatin swish or spit, or oral fluconazole. Okay, and then moving along.
So we'll just end the last few slides with a couple of housekeeping items, and then some practical aspects of starting Betty patients. So we kind of went over most of the important safety information. I will mention that infections have been reported. Obviously, if someone develops infection, then the medication should be interrupted. The patient should be treated and monitored carefully. Evaluate for tuberculosis prior to initiating therapy. And actually, if you read the fine print, it says patients should be monitored during and after treatment, although there is a lot of variability in that as well. Now, inflammatory bowel disease has been reported in patients treated with IL-17 inhibitors, including Bimzlex. If a patient has active inflammatory bowel disease, then avoid use of Bimzlex, and of course, monitor them for signs and symptoms. If they develop new onset signs and symptoms of abdominal pain, cramping, bloody stools, diarrhea, intermixed with constipation, then obviously patients should be interrupted and evaluated prior. And with regard to immunizations, all immunizations should be up to date prior to starting biologic therapy, but live vaccines should definitely be avoided while on it. And the most common adverse events, at least in psoriatic arthritis, includes upper respiratory tract infections, oral candidiasis, as we mentioned, headaches, diarrhea, and urinary tract infections. Now, in terms of administering the medication, it's very convenient. There are the prefilled syringe or the autoinjector, thereby allowing patients to, we can meet patients at whatever their point of preference and comfort is. They come in both the 160 milligram prefilled syringe or autoinjector or the 320, which is twice the volume. And with regard to dosing strategies, it's very easy in psoriatic arthritis. The dosing is just 160 milligrams every 4 weeks. Sakshi, I can never remember the dosing for psoriasis and HS, so I'll let you go over the dosing strategies for that.
Right. I know it's a little different for patients that have psoriasis, either with coexisting psoriatic arthritis or HS. I know it's very easy in the room space where it's just one injection, 160 every 4 weeks. In the psoriasis space, patients, we do every 4 weeks with 320. And after week 16, it's 320 every 8 weeks. And how I tend to remember is that the dose is doubled for our HS patients. So it's 320 every 2 weeks for the first 16 weeks, and after that it's 320 every 4 weeks. Okay, and as was pointed out, it comes both in the prefilled syringe and as well as the auto injector. So we have a few device options to choose from. And if patients have psoriasis with coexisting psoriatic arthritis, you'll be using the psoriasis dosing. Okay, so we talked about efficacy, we talked about safety. If I cannot get the drug in the hand of my patients, what is the point? And this is where I think the slide sort of is important, because if we decide to prescribe Bimzlex for our patients, we can prescribe it with confidence. 90% commercially covered patients have access to Bimzlex. It is first-line IL-17 for psoriasis, and patients that have psoriasis with coexisting psoriatic arthritis in CVS and have CVS Caremark. In Express Scripts, it's a single-step edit. And then, irrespective of anything, as long as a patient has commercial insurance, there is the Bimzlex Navigate Bridge program. And patients can get up to 2 years of Bimzlex while their insurance is pending. So prescribing is really easy, and it has the best-in-class access when it comes to all IL-17 blockers. They have dedicated nurse navigators, and that's also helpful because it sort of there's a lot of hand holding for patients. And then there are field access specialists in case we have any issues on our end with regards to access or getting our patients Bimzlex. Okay, and then this might be, sort of the last or the second last slide. We've talked about rapid response and complete response. 4 weeks PASI, mean PASI. We've talked about PASI 90. We've talked about PASI 100. We've talked about durability of response, where 5 years of therapy, 77% patients held on to that PASI 100 response. We've talked about 5 years of safety data across all indications, and then whether it's bio experienced or bio naive patients that have psoriatic arthritis. Gordon talked about that wall of zeros. And it's a great drug to have in our armamentarium for our patients that have psoriasis and psoriatic arthritis.
And I'll just end by saying that Bimzlex really does offer a transformative treatment result with Bimzlex, but for patients with psoriasis, psoriatic arthritis. But in doing so, the data has really shown a new paradigm by which we can approach these patients. That now it's not just we're not just able to achieve 20%, 50%, 70% improvements in the joints, 90% in the 75 or 90% improvement in the skin, but we can really strive for complete resolution of signs and symptoms of disease, and doing so in a manner that's quick, that's with a mechanism of IL-17 inhibition, but yet this is inhibiting IL-17A and F, and that's durable over time and safe. And I hope that at least over the last hour or so, you kind of seen the data, and maybe it will allow you a different perspective by which to approach your patients with psoriasis and psoriatic arthritis. So thank you so much for your time. I think I speak on behalf of Sakshi. We really appreciate your time and effort. And Ali, we will turn it back over to you to close this off.
Thank you, Gordon. Thank you, Sakshi. So I guess some great points and questions were brought out by our audience. So this is a question for both doctors. How do you manage patient referrals between derm and rheum colleagues? Have you formed a referral network, or how do you advise others listening tonight to build these networks? And I think that's great. It's a very practical question.
Yeah.
So I will take a stab at it from an academic institution perspective. So I work at Mount Sinai. For us, Epic instant messages is probably the easiest way, or sharing a chart note is the easiest way. So that's how I do it. I mean, that being said, I do have a few of my room colleagues who I have, built intimate relationships with, and I kind of know them, and I have their cell phone, and I just text them. And again, it goes both ways. If they have a referral to DERM, I'm their point of contact. So it's really good to pick people that who are approachable, and for patients that have psoriasis and or psoriatic arthritis, just knowing that there is a derm room collaboration is super helpful.
Mhm.
Gordon, how about
Yeah,
you?
and from the community, um, it depends on who's initiating the consult. So if it's and one of the things I've noticed is that many more of our referrals for psoriatic arthritis are coming from dermatologists now. The dermatologists have identified the psoriasis. They usually have them on therapy, and the question is, are their joint pains reflective of psoriatic arthritis or something else? If that's typically the case, then as rheumatologists, we sort of take hold and manage the psoriatic arthritis, and in doing so, we manage the psoriasis. But if it's the other way, where we're referring out to a dermatologist and it's to confirm this is psoriasis or something else like atopic dermatitis, then oftentimes we'll find a partner in community who is really interested and focused on medical dermatology, and who we've created great partnerships with. And at least in the Charlotte area where I am, there are a handful of dermatologists who really have a dedicated interest in psoriasis and other medical dermatology diseases. And we develop a really great working relationship. But I think the important thing is it really doesn't matter whom we submit referrals to. All that matters is that we're collaborating in care for the patients. And if we can get them to zero disease activity, then at the end of the day, that's what's most important.
I think that's a great point. I think what the takeaway is, create your ecosystem, whether it's local, regional, and then work with that, right? Work with your colleagues and be collaborative. Great points. Another question is, what is the most important relative rheumatology data point to you as a derm, and vice versa, as a derm data point to you as a rheumatologist that you've heard tonight?
Great question. So actually, you want to take that from a
Right.
dermatologist perspective?
So I will say that, Gordon mentioned, just even, when we were talking about the PEST questionnaire, that just asking the patients, do they have joint pain?
Mhm.
Because I think, that simple question, especially if there's been a change from their baseline or from prior visits, can be that important clue that he is something going on with my patient, right? So I think for me, really the big take home was like, just asking them if they have joint pain.
Mhm.
Yeah. And from a rheumatologist perspective, I think the most important dermatologic outcome measure would be a PASI 100, so a complete resolution. Now we have such amazing effectiveness and efficacy of these agents. Patients can enjoy complete resolution of psoriasis. And when you'll see the look on their faces and just the satisfaction and the gratitude, just the amazement, it makes treating psoriasis and psoriatic arthritis so gratifying, so satisfying. So for me, that's what I'm striving for, is complete resolution of psoriasis in the skin, just as I'm striving for complete resolution of arthritic symptoms in the joints.
Love that. Now, there's one more question for each of y'all. Then my little twang from Texas came out, but I guess Dr. Khatri, this question is for you. What are your personal takeaways when you review the psoriasis data? Is the onset of action and clearing the plaques your takeaway, or the efficacy over time resounding to you as a derm?
But I think we are spoiled with Bimzlex because we get both.
Mhm.
We get that speed of onset and the durability, or the 5-year response that we talked about. So I think with this drug, I don't have to choose what I'm going with. For that patient who's like, how soon will I see a response? Here, this drug is going to work for you within 4 weeks. Or for that patient who's like, what, doesn't matter what the speed is, I just want to stay clear, and I want to stay clear for long periods of time. Here, you have a drug that works for that as well. So really with Bimzlex, I will say we really don't have to be in that choosing one versus the other group anymore.
Well, that's great answer. And the last question, the last 30 seconds, Dr. Lamb, what is the relevance to you for the ACR 50 data presented here versus what you typically see in clinical trials highlighting ACR 20 data? Can you briefly explain the real world impact for our audience here, the patient presenting with both psoriasis and psoriatic arthritis?
Yep. So ACR 20s is a construct mainly to get FDA approval. But again, a 20% improvement doesn't really mean much to the patients. ACR 50 is a higher bar. It was more aspirational at first, but now it's realistic. But again, from a patient's perspective, it doesn't mean much. They want complete resolution of signs and symptoms of the disease. Even if they have residual disease activity, it can impact their quality of life and their daily function as well. So for me, while ACR 50 was a bold endpoint, we're shooting for something much more realistic for patients, which is complete resolution. And if we can do that, I tell patients my goal is for them to lead a completely normal rest of your life. They don't know what an ACR 50 is, but once we establish what normal is, that's our goal, and that's what we strive for.
Amazing. Thank you so much, Dr. Lam and Dr. Khatri, for a fantastic webinar series. And with that, we'll conclude our webinar for this evening. Thank you, everyone, for attending, and thank you, UCB, for sponsoring this amazing webinar series.
Thank you. Have a
Thank
great
you.
night.
Bye-bye.